Good afternoon. I'm Joe Duffner. My company is DirectLink Technologies, and we're very happy to be a sponsor and part of Big Data. DirectLink Technologies is a technology center and co-location facility. We house data. We are the brick and mortar for our customers' IT infrastructure. One thing in particular that our customers like about bringing their IT infrastructure to DirectLink is the connectivity options we offer. We offer a high-speed, low-latency cloud on-ramping from our facility to anywhere in the world. So our customers find that co-locating in our facility and connecting to other data centers or the public cloud providers is very easy to do if they're with us. So I'm very pleased to be able to introduce Christina Scolari of Omnicell.
Everyone, is this good? You guys hear everybody? Everybody good? Okay, great. So again, my name is Christina Scolari. I am a clinical strategist with Omnicell. I will go into briefly who Omnicell is, a little bit more of my background, just in case you guys are not familiar. But today we're going to be talking about how Omnicell, specifically the Performance Center within Omnicell, how we are tackling big data in regards to patient outcomes at this point. So really quickly, who is Omnicell? We're a medication management leader in healthcare, right? Everybody seems to know us from our hardware. Cabinets on the units that the nurses are touching every day, to the pharmacy robots within central pharmacy that's dispensing all the medication, IV compounding systems, all the way to what we're going to be talking about today, which is the Performance Center, analyzing the data from all these wonderful hardware systems, right? So just quickly a little bit about myself so you understand the context of what a clinical strategist is. My background is I went to Pitt for both undergraduate and graduate. Hail to Pitt. I started in nursing, then from there went to an administrative role, went to the School of Law for health law. So Pitt is where my heart is at. Right now I am a second-year pharmacy student at The Ohio State University as well. And then this is probably going to make a lot of sense to you guys. So you see my tattoos and this makes sense, right? Marine Corps veteran for 6 years. Now everybody can piece it together. So I actually did combat and trauma care in the Marine Corps for about 6 years. So I had the clinical component background as well as the regulatory and compliance background that we needed to be able to look at this data, make changes from a big healthcare perspective, right? So what is a Performance Center? If you were here in the last speech, Suzanne couldn't have teed me up any better, right? Because she basically talked about how you need to have the clinical eye on the data that you're looking at to make actionable insight on it, right? Because big data can do a lot of things in terms of machine learning when we put it through algorithms, but it doesn't mean a whole lot if we don't have the context around it. So we're a team made up of data scientists, statisticians, different individuals who are really well-versed in machine learning, as well as clinicians. So nurses, pharmacists, pharm techs, anybody who's had that clinical care component in their life for several years. We marry those two individuals together, essentially. The data scientists mine the data, create all these really cool algorithms, tools for us to use, and then we as clinical strategists are the individuals looking at it saying, this doesn't make sense from a medication perspective, or we understand why the algorithm spit that out, but contextually, that's not really something we would implement within the hospital, or it's something we would, right? These are just some of the other things the Performance Center does. So essentially, just so you're aware of what the Performance Center is, how we're structured, we take all of the data from all these cabinets across all of our service hardwares, right? We're in just about every hospital across the United States. So we're able to pull that data in and provide actionable insights on that. So primarily we started in a supply chain type of arena when the Performance Center started, right? We started looking at the supply chain, understanding how we could make, your min and maxes better, make sure you're not expiring meds. We actually have an algorithm that predicts medication shortages, predictive price increases. All of these things are on the supply chain, right? But we kind of noticed there's a piece missing, right? We have all this great data. It's a lot of data, as Suzanne had mentioned before, comes from umpteenth million disparate systems, but we can do something with it, right? As she had mentioned in the last one, healthcare is so popular right now because it represents almost 18% of the GDP. It's crazy. That's nearly 600 billion, not million, not trillion, billion more than what was expected for the United States in regards to their size and wealth. Okay? But providers now are being paid based upon the outcomes of patients. So they're vested in it, right? To understand how their outcomes compare to others and how they can improve those outcomes. As well as provider decision-making is no longer just based upon what they learned in school and what they learned in residency and what their hospital is doing, right? Physicians, providers, nurse practitioners, whoever it may be, they're actually going out doing their own research to understand what other people are doing in the industry that would decrease their outcomes in terms of length of stay, readmission rates, different items like that, right? This is just a little visual to basically show you where the GDP spending is expected to go. By 2020, it's expected to be almost 20% of the GDP, with 75% of that going to chronic care, right? 75% of our spending is dealing with chronic care conditions. So what can we do with all this data that we have to somehow lower all of the costs associated with that? So you guys are very aware, I'm sure, with how healthcare is currently utilized in the hospitals. But where can we, Performance Center, kind of tap into this? So some of these examples, this is not exhaustive in any way, shape, or form, predicting patients' income in regards to coming in and out of the hospital, not what they're making money-wise, to be able to tailor the staff to that, right? EHRs, which we're all familiar with, pretty popularly implemented. Real-time alerting, so everything we do is in real time, which is really cool. Help in preventing opioid abuse in the US, the hottest topic right now, right? And we'll talk about how we are actually targeting that and tackling that. Enhancing patient engagement in their own health. Susanna talked about that, right? We're more invested in looking at what our healthcare providers are prescribing to us. We want to look it up after. We want to look up our disease processes rather than just trusting, right, that what they tell us is correct. Use health data for better informed strategic planning. This could be from the supply chain all the way to patient specifics. And that's what we're going to get into a little bit more. Research more extensively to cure cancer, any other chronic diseases. As we had mentioned, 75% of the spend right now. Predictive analytics, we'll talk about that. Reduce fraud. This can be billing fraud. It could be diversion within the hospital system, which is something we look at as well in regards to all of the people touching the medications. Telemedicine, integrate medical imaging for broader diagnosis, prevent unnecessary ER visits. So today we're going to show you how we at Omnicell take all this data and we can help prevent opioid abuse in the US. We use that for strategic planning about how to prescribe to individuals. We do it through predictive analytics. Okay. So current obstacles, disparate systems, right? Healthcare data is in so many different systems within the health system just itself. If we're just looking at a health system, let's say UPMC, AGH, whoever it may be, right? Their hospitals have one portion of it in billing and claims, finance, the EHR, quality data, right? We have to go to all these different people to get just one question answered. Healthcare's behind, right? We are behind. All the other industries around us seem to be innovating using predictive analytics. We need to get away in healthcare from this regression-based model that we've been using for so long, right? We need to get into the more machine learning predictive algorithm type of platform. This is just a nice chart that shows you how convoluted the path is to getting the data that you want in a hospital system and what our customers deal with. At the bottom, it says, it's kind of hard for you guys to see, it says spreadsheet mania, right? All of our customers end up taking 10 different data platforms from different places in the hospital, and they just use Excel spreadsheets to hope it works. This is not efficient, and it's not something that I don't envy that at all. So here's a challenge that I was posed by a customer, and I'm going to pose it to you guys, right? As a hospital leader, you're charged with assessing the efficacy of a certain medication, right? I'm going to give you a very specific example. In this example, Ofirmev. So do we have any clinicians in here who actually know what that is? Okay, so in its easiest terms, Ofirmev is Tylenol. It is acetaminophen in liquid form. That's all it is, right? We can buy acetaminophen as a hospital, in the hospital, for pennies on the dollar, right? But once you put it in an injectable form, it's $34 a dose, okay? So it's marketed to these hospitals as an alternative to using opioids because it controls your pain. And oh wait, it controls your pain better, so you're gonna get your patients out of the hospital quicker. Don't worry about that $34 a day. It'll make up for it when you get your patients out of the hospital quicker. How do we know that's true? So I feel like I can say these pretty well because I used to work for Bayer. So I used to work for a pharmaceutical company. I know how it works. So again, as leaders, we want to utilize medications that mitigate our risk to contributing to the opioid epidemic, control our patients' pain, right? That's really important. We don't want to be the industry that says opioids are always bad, right? They're not. They have their place, right? But where is their place? Okay, we need to understand that versus just liberally using a medication across the hospital system because it's available to us. And we want to control our costs. We want to get patients out of the hospital quicker, and we want to make sure they don't come back so we don't get a penalty. So how do we tackle that in a hospital, right? How do we even address that question? Just Ofirmev versus opioids is what we're showing here. Current solutions. In a hospital system, what you would do to address this question is you would run what's called either a drug use evaluation or a medication use evaluation. Very similar. Do you see the bottom? The goal of either is to promote optimal medication therapy. The DUE is just done at an individual patient level. The MUE is done because they want to look at outcomes at a more holistic level. So it's just dependent on what your hospital system wants to run the study, right? Either or they're pretty interchangeable. But this is what you would have to do, run either one of these studies within your hospital system to be able to answer that question. Now, what's the process look like to do that within a hospital system? Before we even get to formulating the MUE design, we have to find someone to do it. If we have a resident, fantastic, right? We use residents like it's nobody's business. But at the same time, you better hope you didn't ask your resident to do it in June because they're gone by July. And this is not a 1-month task, right? And we'll show you that in a little bit. So let's say we get someone to do it outside of their normal job, because we all have so much extra time, right? We formulate the MUE, evaluate the criteria that we want to look for in the medication's use, investigate if we need ethics committee involved. We actually run the DUE, develop and implement improvement, and then track it. Okay? So where do we come in? Where does the Performance Center come in? The initiation and conduction of the MUE is what takes the most time in this process. So we want to cut that down and we want to make it standardized because we have all this fantastic data to do that with. Varying approaches. So if you're in a hospital system right now, you don't partner with the Performance Center, you don't have any other vendors that you work with, this is the way that it would go, right? You would collect data from disparate systems, as we mentioned. We would go to the EHR for our formulary. We would go to billing and claims to find out what was actually administered. We would go to quality to see who has been readmitted, if there have been any hospital-acquired infections. We would take all of those data sets, and we would manually manipulate it in that Excel sheet, right? And then we would come up and formulate different conclusions based on a limited data set. What do I mean by that? I mean that I can only, as a hospital, evaluate how we are doing, right? I don't know how we're doing against anyone else because I only have my data. So if we think we're best in practice, what are we basing that upon, right? Just our own data. So some hospitals may pay for aggregated data on a national level. 9 times out of 10, it's never going to give you that granular level to actually compare yourself to a similar cohort, right? So how would the Performance Center do it? This is ungodly small. I apologize. So we would stream the data in to our already in place OIS server, right? And they're already in place because our cabinets are already through these hospitals. So we would stream that data in right from there. It's encrypted on the way there, and then it lands in our AWS instance in the Cloud Data Platform, encrypted there as well, okay? Then, once we run it against some algorithms, run it through machine learning to find different variations of outcomes that we want to be able to find, at that point, we support it with the insight from our strategists, right? So much as Suzanne said before, the data is only good as the person looking at it, right? So this data can tell us a lot of things, but we have to put it in front of our clinicians to be able to say, does this make sense, right, from a clinical perspective? We put it in front of them, and then what we do is we take the next step and we run it against our 150 plus hospitals within our data set. So as I mentioned before, as a hospital, you're just looking at how you're doing against yourself. But Omnicell has this wide plethora of data available to us in which we write in all of our contracts, can we use for benchmarking? They say, yes, it's fantastic. So we're able to tell you, hospital in the Northeast who has 250 beds, what every other hospital in the Northeast with 250 beds, that's a specialty hospital for children's, whatever it may be, how they're doing in regards to their outcomes. It's very specific. So if the process right now in a hospital isn't broke, why are we going to fix it, right? It works, I guess. What's the problems, though? For that one question that I asked you guys, on average, it takes about 2 FTEs to complete that, in about 70 hours. Just that one question, to be able to collect all that data, to do it on your side job, as well as the inability to benchmark, like I said. If you don't, as a hospital, want to pay for a different data set, you're subjected to CMS data that is at its best from 2015 at this point, publicly available. So it's dated and it's very non-specific. So back to the challenge. Now knowing how the Omnicell's Performance Center would approach this challenge, I'm going to run you through an iteration of what our product essentially looks like, how we're challenging it. So again, does the utilization of Ofirmev within certain DRGs, and DRG is a diagnostic-related group. All that means is every time you go into an inpatient facility, say you broke your leg, they give you a code, and it's just a specific code for everyone who breaks their leg. It's not specific to you. Just That's what the government pays them. They said, okay, you came in under DRG 701, broken leg. On average, this is what it should cost. We're going to pay you that amount. So it's in our best interest as a hospital to not spend as much money, right? Get you out of the hospital quicker to make sure that we actually make some profit on that reimbursement, right? What this is going to do, so you're going to see the tool is going to move itself. What you're going to see is that I'm able to pick up here. I want to see all patients in my health system that received both an opioid, and then we're going to go over here and received both an opioid and Ofirmev, okay? This is actual real hospital data that you're seeing. It's just masked. So what this does is it's going to pull up every DRG, every diagnoses that patients received. Oh, I'm in the way. Patients received that combination of medications in. Okay, so the highest combination of that medication was received in a coronary procedure. We click on that, we can see all the specifics. So it's kind of hard for you guys to see. It's actually really hard even for me to see, and I'm right here. It shows us all the opioids that were prescribed, the doses, and the cost, as well as that Ofirmev. Okay, so for example, there were about 1,400 doses of opioids prescribed for about $2,500 amongst 142 patients. Ofirmev, there was, I gotta look at the doses, but I know it's about $71,000 spent just on Ofirmev, nothing else on that, right? We're gonna run through the next iteration, and what this shows us here is the length of stay when you're using both medications in this hospital system is 9.1 days. Now, knowing what we know about Ofirmev and how it's marketed, we would expect that when we remove that from the data set, the length of stay would significantly increase, as well as our doses of opioids would significantly increase, because this drug says we're going to decrease your length of stay and your patients won't need as many opioids, right? That's what we should see happening when we use this tool. Again, that's just pretty much what I stated. So what do we find? Patients receiving both of the medications, there were 142. Patients receiving only opioids, 175. The removal of Ofirmev from the treatment plan for just this one DRG was associated with a decreased length of stay. So it went the opposite way, right? They said it should have been helping, right, if you add Ofirmev, but it's actually doing the opposite. So it goes from 9.1 to 9.06. Not significant, but it's not going in the right direction at all. For opioid doses, we went from about 1,400 to about 1,700, right, when Ofirmev was taken away, but our patient load increased by 23%. So the increase in doses administered is completely in line with the increase in patient volume. So what does this tell us overall? Approximately $70,000 spent on 142 patients on a drug that neither significantly decreases your length of stay or mitigates your risk to the opioid epidemic. So why are we utilizing it, right? We just ran through together in 2 minutes what we would do for a hospital system that takes them 70 hours and 2 FTEs, right? It's a very pointed question. This is how we're using big data. The next step of this, which I am limited to time, right, would be that we would show these specific hospitals other like facilities that are utilizing this medication or this combination of medications in similar formats, right? So this has been beneficial to hospitals in regards to utilizing it for their antimicrobial stewardships. And even though you guys maybe aren't a clinical audience, you've definitely heard about superbugs, right? You've heard about MRSA. You've heard about individuals prescribing too many antibiotics to the point that they need to be regimented. We're able to show hospitals where those antibiotic prescriptions and administrations are actually getting patients out of the hospital quicker and making sure they're not coming back, right? We can see the readmissions to make sure that they are not showing up again in the hospital system and we're not getting penalized on them. As well as this was specific to opioids, right? Where can we mitigate our risk? Because right here, we're prescribing a medication that doesn't decrease our utilization of opioids, right? So we're just spending more money and we're not helping ourselves. So why are we doing it, right? So this is an opportunity type that we would provide to our customer, and then they go forth to their P&T committee, which is Pharmacy and Therapeutics Committee. They're the ones that own the formulary, right? They say what is allowed to be administered in the hospital, what is not. So a lot of things that have happened with this particular medication is that it's been completely removed from the formulary because it's not doing what it's supposed to do and we're spending a lot of money on it, right? So just lastly, just some points. You know, big data is only as powerful as the methods and interpretation, right? So we have a lot of great data, but we need those clinicians to be able to look at it, find a way that it makes sense for our hospitals to utilize, and then go forth utilizing that. We're consistently creating different ways of utilizing this type of tool, right? We're taking practices from doing well to being best in practice. and best in practice is actually based on what everyone else in the industry is doing. So that's what I have for you guys today. Questions specifically on what we are doing in the Performance Center related to patient outcomes that you guys can think of. Yes?
When you're evaluating readmits, are you, if you have similar hospitals within the same region, do
Yes.
you report that out to show readmits within
Yes.
their
Yes.
person?
So we actually have a really cool tool that it will take, you can specify it to what you're interested in. We actually give this tool to our customers. So they're able to specify within the tool, I want to see all hospitals within my region, right, the Northeast, or you can just say in Pennsylvania, whatever it may be, whose bed size is also between 300 and 400, whose med spend is also between this, and our specialty is X, Y, and Z, right? We have been lucky enough to have such a big data set in hospitals that are willing to be the benchmark for us that we're able to provide that all to you. The only thing we aren't able to provide is the hospital name. But you get the data at the most granular level. So if you want to see exactly how other hospitals are utilizing those two medications, we're able to provide that to you as well, versus just, oh, you guys are 10% less than the national average. Well, what does that mean, right? We're able to give you the actual data from that just without giving you who the hospital is. So you get a dashboard as a customer to be able to show. You can go in there. We run these studies typically for the customers. So they don't have to do the legwork, and we have the clinicians, but because this tool is available to our customers, they're able to do this as well. So if they have free time, they're just curious about something, they can, log into it, play with it, as well as see what are their other benchmarks. For readmission, for any of the things that you just saw, they're able to look at other hospitals. Yes?
How do you deal with, take this example of medication, dealing with selection bias in, if these were not randomized clinical trials, this certain patient was more severe, therefore we actually gave them these more heavy-duty medications in the first place.
Right.
How do you adjust for?
Absolutely. So when you're assigned a DRG in a hospital system, there's two types. There's an APR DRG and there's an MS DRG. MS is Medicare, Medicaid. APR is everyone else. When you get that APR DRG, you're also assigned a severity of illness and a rate of mortality score. So 1 to 4, yes. So we're able to group those patients based upon our most severe categories, right? So our recommendations are going to be different for individuals who have a 4 out of 4. They're most likely our most costly, most sickly patients. We can actually look at unit type as well to be able to say this patient's in the ICU. Their treatment's going to be a lot different in medication utilization than someone on a med-surg unit. So we account for those based upon the severity of illness and rate of mortality. Anything else? Yes?
Offering where you just have access to the data and not the full suite?
So this is it will be, it's not GA at this point, it's in beta, will be GA by the end of the year, this specific product, and it will be standalone. It will be offered as a standalone. So the tool is no different than the data set, right? It's just put in a pretty way. We can't provide you, we'd be able to provide you raw data, just again, you wouldn't know who it was. So yeah, it's absolutely something that we're able to provide because we understand that some systems, they have people in place to do it, they just don't have the data. So yeah, we absolutely. Anything else? Cool. I appreciate it, guys. Thank you.